Hello, we are live. Dr. Rachel Pope, and if you, is it Chidi or Chide?
Cheaty.
Chidi, close. But yeah, I mean, I'm globally renowned for massacring people's names. So I am sorry. We are now live, and thank you very much for joining us because you have caused quite a stir. I can honestly say I don't think I have ever seen a researcher take to social media and say, keep calm, people, because your post presentation, which is a great thing for pointing us in a brilliant direction, seems to have caught the imagination of an awful lot of people. So, Dr. Rachel Pope, and if thank you so much for you. I will just give you a quick speech. Dr. Pope, you are a certified practitioner, obstetrician, gynecologist who also does research based in Cleveland. And Iffy, you are the pre-med student who's literally been thrown in the deep end, probably quite unexpectedly, who is the lead author on this study, which is huge, by the way. And you are at Cape Western University School of Medicine in Cleveland. So let me start with saying, you thought, Rachel, I heard you saying to Dr. Karen Tang that you thought that this would be a teeny tiny step, but one with a big. What happened?
Okay, so here's what happened. Evie signed up for a class to take with me, Women's Public Health. And as part of that class, each student has to do a research study. So I encourage them to use database studies. I encourage them to use survey studies because they only have the length of the course, about 6 months, to complete something from beginning to end. We cover all different public health issues for women, whether it's reproductive, whether it's menopause, right? Everything. We try to run the whole gamut of what's important for women globally. And if he was really interested in this topic that I had proposed to the class on perimenopause, we explained the Women's Health Initiative and that, after years of back and forth trying to understand, are hormones safe? We've finally figured out that there's a window of opportunity to give hormone therapy for women, and that's the first 10 years after menopause. That's the safest time, right? It doesn't mean that you can't start earlier, you can't start later, but we know that's the safest time. But in my clinical practice, as an OBGYN who sees many women going through perimenopause, I notice that that's when the symptoms really start on, and why not give them the same or similar treatment, right? Traditionally, people have given women who are in perimenopause, that's while they're still ovulating, they still are in reproductive potential, they tend to give them oral contraceptive pills or something that's going to help prevent an unintended pregnancy during this time. And while that might mask the perimenopausal or menopausal symptoms, it may not actually be treating it. And so this is something I've seen anecdotally. I've seen many other women from my partners and colleagues who take care of this population who do really well during perimenopause with menopausal hormone therapy. So that's estradiol or estrogen with a progesterone, specifically micronized progesterone, which is we have the safest evidence for, or an IUD, or something that's going to also inhibit ovulation. There's lots of progestins like agestin that can do that. So my question was, if we know that the safest period is the first 10 years of menopause, wouldn't it be safer or just as safe in the 10 years prior to menopause, during perimenopause? And so I asked the class, would anybody want to use the database to look into this? We look at the same issues that the Women's Health Initiative looked at, specifically heart attack, stroke, and then cancer risks. And Ify was interested. So she took this upon herself to learn how to use the database, how to extract data from it, how to draw queries from it, and to try to answer this question. But the caveat that I've tried to tell everyone, I've told Dr. Tang as well, that these are just associations. So what we can pull from the database is only as good as the codes, the diagnostic codes that are used when a healthcare provider sees a patient. So he or she may not remember to put in all the codes at each visit. It also means if someone started on estrogen therapy, they may not have continued it the entire time. All we can see are these snapshots. So it is severely limited. But the reason we're excited about it is it's a massive database. Over 120 million people are in that database. So we're able to draw, sort of patterns from such a large number. This is not 120 million who are going through menopause. I also need to make that clear because I kept seeing that repeated in the news, which is not true. So of that 120 million, files, we withdrew the specific women who are on menopause hormone therapy either 10 years before the average age of menopause or 10 years after. And that's really where we honed in.
And when you did that, and actually I'll come to you in a moment, but when you were doing that, when you say you're looking for associations, I mean, basically the first press release that came out, which sparked all of the very excited reaction, was saying 60% lower or 60% risk, 60% reduction in risk of breast cancer, heart disease, and stroke. How accurate was that in comparison?
Yeah, so that's not accurate. We cannot say with associations that there's a reduction of risk. We cannot say that there's protection. That was a complete misinterpretation of the results. There's a whole debacle. We could do a whole segment on media misinformation. If things were not double checked, there's a whole problem inherent in that, right? So when you look at associations, initially they were looking at a 60% lower number of cases, but that wasn't even across the board. You'll see people say 60% reduction in heart attack, stroke, and breast cancer. That doesn't even make scientific sense. We wouldn't have gotten the same number for each one of those things, and we didn't. So somehow they got this number 60% from the initial data. That wasn't even the data that was used in the final poster. And so that just spread like wildfire because I think people are wanting this information and they want that to be true. I want it to be true too, but I also we have to go with the real science and the data, and we cannot draw conclusions about associations. We only can see, okay, there's a smaller number, but I'll explain. The women who we followed in perimenopause are 10 years younger than those who are 10 years after menopause, right? And we only have been able to follow for the last couple of decades because we haven't been using electronic medical records very long. And this data comes from electronic medical records. So these are younger women, right? It doesn't mean that they might not develop breast cancer later or have a heart attack later or a stroke later. We just haven't seen it yet. And what we wanted to look at from the data was, is it just as safe? We wanted to make sure that it's not any more dangerous to start hormone therapy during perimenopause. And that's the only thing that we could maybe surmise, that at least from these associations, we have reason to believe we should do the prospective data. But so far, from what we can see of these associations, there's nothing dangerous potentially about starting. That's the clinical information I'm hoping to answer. But even with the retrospective database, we haven't quite answered that yet. We're just looking at purely associations.
Yeah. Ify, when you approach these 120 million bits of data, that is just a huge amount of data. What limitations were there? Were you able to also get out of that what types of estrogen they'd been prescribed, or what types of progesterone? I understand you excluded progesterone in the data. How much would that actually skew things as well, if we're thinking that the progestins might actually be more risky in terms of breast cancer per se than other things? What sort of limitations were there when you were looking through it, and how did you apply them when you were going through that vast amount of? It came down to what, about 150 records in the end, 150,000 records in the end, yeah?
Yeah. I think what the biggest problem was to the diagnosis of menopause and actually defining which women were going through menopause. And so we decided to use ICD codes, which there's limitations with that because not all women are diagnosed with menopause clinically. But looking at, I hoped that my propensity score matching would help eliminate a lot of the limitations, so we could have comparability between the cohorts. And so we compared, because Trinetics database we use only has de-identified data, so we're not able to go in and look at individual patient records and their individual characteristics to compare them with each other. But the database lets you do some matching between the cohorts to eliminate a lot of the covariables that could affect things. So their cholesterol, BMI, age to an extent, race, ethnicity, all those things we use to help make those more comparable.
And what about people who've gone through early menopause or POI?
There was there was like some matching on age.
We can't really define that, unfortunately. We didn't use the ICD code for premature ovarian insufficiency, so we can't know that, unfortunately. And Trinetics is not great with lab data. That's the other thing. You may need lab data to confirm those things, so that's another limitation.
Yeah, yeah. Other confounding factors. I mean, you mentioned before that they were younger. Are they also more likely to have, biases of, higher socioeconomic class? Basically white middle class women like me who are probably more likely to eat well and have better, exercise regimes and all those sorts of things.
We don't know. We don't get any of that sort of rich contextual data from this retrospective database data, which is why I feel like the biggest take home from this is that we all should be doing this research, right? There are other databases out there. I encourage the researchers out there, pull your data, look at your own charts. Look at, if you have been running a menopause clinic for the last 30 years, pull your files and give us your results, because you may actually be able to look at your individual charts and tell us what is the socioeconomic contributors, what are those socio-demographic factors. We know that those have to do with how healthy people are. And so this is a limitation of our database, but there are others out there who I'm sure have that data, and we'd love to see people research and publish it.
Yeah, absolutely. In terms, you mentioned there, a lot of them will be on contraception as well. How would you work if they're on contraception and they are having these sort of menopause symptoms? You've mentioned that you've seen people doing really quite well when you give them hormone replacement when they're in this perimenopause phase. How do you work that then with making sure that if they don't want to get pregnant, that they don't, but they're also getting the benefit of the menopause replacement therapy?
So there's lots of ways to do this. I'm actually in a urology department at University Hospitals. I'm in the Urology Institute, so I've got great colleagues that perform vasectomies. So oftentimes when I talk to my patients about this, if you're finished having your family or creating your family and you want to now be on treatment and not worry about the contraceptive piece, maybe ask your partner to take one for the team. And I've got a colleague to refer them to. That's the first one that we often talk about. But the Mirena IUD, the levonorgestrel IUD, actually is contraceptive and protects the uterus theoretically from estrogen. So it's another great solution, especially as women are going through perimenopause. They tend to have bleeding changes, right? So remember, I'm a gynecologist. I take care of women who are having bleeding issues. We don't want to jump to hysterectomy. We want to do the least invasive things first. And so levonorgestrel IUD is fantastic for protecting the uterus when there are bleeding changes. And so I'd like to see more research published on how it might be used with hormone therapy as well. And then we have a couple progestins that work as contraceptives. There's Slind, that's a contraceptive. Sometimes that's the one that my patients are willing to go on, while they also use an estrogen patch, for example. There's also agestins that do inhibit ovulation, although they're not meant to be contraceptives. And so we kind of try to figure out, are we also dealing with a bleeding issue, or do we just need to be prepared for one? Because a lot of my perimenopausal patients, that's what brings them into the office is really the changes in bleeding. And so we have to address that. And then we address the menopausal or perimenopausal symptoms like sleep changes, mood changes, vasomotor symptoms, those hot flashes, everything else.
Yeah, it's a big ask, isn't it? And as you sort of said before, that we have, most of the studies are done in postmenopausal women. And I don't know if you've come across Susan Davis's work now, where she's trying to look at when symptoms start across that reproductive health cycle. And she's found that it is actually quite different. And there are some that seem to, span the entire cycle of, pre-menopause to post-menopause, like anxiety and brain fog. They seem to be persistent, for want of a better word, whereas others that we thought were sort of starting later seem to be starting earlier, which therefore also makes it doubly important that what you're doing comes to the fore, because if we are going to be starting hormone therapy much earlier, we are going to see people on hormone therapy for a lot longer. So where would you look at this go now? And also, how do you between the stresses of life and perimenopause?
Right. It's about connecting the dots, right? So one of the things I do with a couple of my colleagues, Jean Marino and Anna Myers, we run a menopause retreat because we realized we didn't have enough time with our patients in the office to go through all of the psychological and the social aspects and just even the educational component of perimenopause and menopause, and understanding that it's not just hot flashes. Also, your change of mood, your increased anxiety, new symptoms that are like ADHD, all of these things might be reflecting perimenopause or menopause. And I had asked my friends and sisters actually who were going through menopause already. They're 10, 9, 8 years older than me. And I asked them, what would you do if you notice the skin changes? What would you do if you notice these sleep changes? What would you do if you notice the hot flashes? And they told me they would see a different medical professional for each one of those things, not realizing that it's all connected to perimenopause and menopause. So the more information we get out there from, as you said, Dr. Davis and others who are looking at when do these symptoms show up, how common are they, what's the prevalence, and we connect the dots that that's connected to hormones, and it's not just a new psychological disturbance or new skin disease, right? That all of these things are connected, then we'll get women that information, that empowerment, and we can really get them treatment because there's treatment available.
Yeah. If we're moving forward and you're going to, if you haven't been put off by this and you decide that you will continue on doing a bit of research, are you looking forward then to actually moving on to the next phase of this, where you can actually start moving it from observational to actually seeing if there is cause and effect, and what would come next?
No, yeah, definitely. I would really love that. I'm in our MPH program right now, and so we do a lot of studies on or a lot of classes on randomized controlled trials and actively the gold standard of research. And so I think that would be really awesome to do. I was telling somebody at the conference, I hope I can solve menopause before I go through menopause myself. So I think that would be really awesome.
That would be really awesome. That's very, very true. In terms of getting it to that point then, what do we need? Because we do know there will be people who will be holding this up for a very long period of time going, well, this is what it shows. So it's going to be very hard to sort of, put that down. How do we get to the point where we can actually say, yes, we can change practice safely now? What do we need? What are the steps that we need to put in place? Research.
We need research funding. Honestly, we need more than just those of us that were at the Menopause Society doing the menopause research. Some really interesting questions have been posited to me on social media from all of this attention. Women who said, I had estrogen receptive positive breast cancer. If I had started estrogen in perimenopause, wouldn't that have been bad for me, right? So there's so many nuances, and that's breast cancer and is not my area of expertise. So we need experts in all of these different facets to be looking at where menopause is reaching, where menopause is influencing their field, and where we could be helping women to make better informed decisions.
Yeah, absolutely. You are at the current moment in the US, and this is another example of when the US sneezes, the rest of the world catches a cold. You're in a very, very difficult situation when it comes to funding, especially for women's health. How much do we think that we can actually raise this so we are actually making sure that it does get the funding that it deserves, and it's not just
we're seeing individuals with philanthropy step in where our governments are stepping back, right? And so I think that's massive. I love seeing what Melinda Gates is doing, what so many individuals are doing to try to put funding into women's health. That is massive, and that's exciting. And we need that so that people can adjust their research accordingly, right? Oftentimes scientists have a few different things that they're researching and they follow the funding, right? For a long time that was on breast cancer. For a long time that's been on HIV. And we need something on perimenopause and menopause and women's health, because then we'll find researchers across the gamut who focus their attention on that.
Yeah, absolutely. Because I know you've got a race in a couple of minutes to jump on a plane, but just quickly before you do, when you mentioned there the difference, you were looking at differences in rates and things like that, and that by accident the 60% was applied to all of these things when it wasn't quite accurate in the press release. So in terms of the rates themselves, what exactly did you find? How much of a difference did it make in lowering rates, apart from just excluding
do you want to explain the hazard ratios or the risk ratios, Evie?
Yeah. So we used like 3 different ratios for the results, but I think hazard ratio is the most applicable as it applies for people that like drop out and like don't follow up with their like health records. And our hazard ratios for breast cancer within perimenopause and menopause were above 1, so it was like about like 1.6 and like 1.9. And so a hazard ratio of 1 means that there's no difference between either group. And then a hazard ratio above 1 means that there is a higher risk in the previous group. And so basically what that means overall is that there was like a 64 and like 98% lower risk, like, or lower hazard within breast cancer for women who took during perimenopause or menopausal hormone therapy, which does not attribute like what Dr. Pope said a lot of times is not association and not causality. And then the hazard ratios for stroke and heart attack were about like 1, like maybe a little bit, like the 95% confidence intervals, a little bit above and a little bit below 1, which is showing like no difference in risk.
Okay, so basically there's not a great risk associated with this, but there is potentially a benefit if we can actually show this later on in other studies.
Yeah.
Yeah. Whenever I see
the fact that we found that there's a difference is really what we are looking for. Sorry to interrupt you, but that's what we wanted to make sure that it wasn't higher risk than what we already see for women who are post-menopause or the first 10 years after menopause. And that's basically what I would take from this, that we don't see a difference in rates between those two groups, especially over the limited number of years, which is only about 20 years maximum that we're able to observe.
Yeah. And was there could you pull out any difference between oral versus transdermal estrogens?
We haven't looked at that yet, but it's possible. And so that's one of the things we want to look at. We can pull out the actual specific prescriptions. It gets a little dicey as people are prescribed differently, and we want to involve as many charts as possible, but also not accidentally include someone who's on an oral contraceptive, for example. But there are some other databases that are a little bit better at doing this, so we're going to be exploring using those as well.
Okay. And can you look at how long people were on the treatment as well?
Yeah, with the Trinetics database, it's not very, there's ways that you can double check that someone had, a refilled prescription, for example. But it doesn't mean that they didn't get it somewhere else, or maybe they moved and something, there's a lot of issues there. We basically could only see was someone prescribed this at any time during that time period. With the other more up-to-date databases that we're hoping to look into, we can actually look at how long were they using this, did they fill their prescriptions? We can actually look at insurance claims and not just prescriptions.
Yeah, although they often are taken out of context as well, aren't they, with the sort of the data again, confused with cause and effect.
Exactly.
Yeah. So take-home message from both of you, and first of all, are you going to go into clinical practice, do you think, or are you going to stay in research, or are you going to combine the two?
I definitely want to combine the two. I've always really wanted to do research, and I didn't know I could also do clinical practice. And then Dr. Pope really inspired me, so I was really, really happy that I could be able to do both of them. But definitely,
yeah, I think it's a good thing, because a lot of the criticism that gets thrown at people who do research is like, well, you don't see patients, but you actually do, and so you've got the best of both worlds in a way. I think it's a good thing. And Dr. Pope, your take home.
Sorry, I couldn't hear the last part that you just said.
Your take-home message.
Oh, take-home message, more research is needed. I want women to know that there's treatment available. I don't want people to be afraid of using hormones to treat symptoms, but please know that our findings are just associations. They do not mean that there is protection or reduction in your risk. And every single person's an individual, right? So these databases are not telling me, your specific medical history. And so please see a healthcare professional. Menopause certified provider is the best. If you need to find someone, go to the Menopause Society's website and look for find a provider. And sorry, I lost my light here. But go to the website and find a provider. You type in your zip code or your location, and you can find a menopause certified practitioner, someone who is seeing patients like you every day and can tell you what your risks and benefits are to the best of our ability. And really, we need more research on this because we're not able to guide people when we don't have data.
Yeah, brilliant. All right, thank you both so much for joining me. I know we've got, so I will, and good luck in the future.
Thank you so much. Thanks for
Thank
having me
you.
today.
Thank you.